Hello.
Hey, good afternoon.
So it's disabled screen sharing right now.
Okay, hold on. Let me edit that for you.
All right, so you tell me when to start.
All right, good afternoon, everyone. Thank you so much for joining us for day 2 of our inaugural Inclusive Excellence Week. We have a real treat today prepared for you in the person of Dr. Dina Garcia. And she's going to introduce herself, but her topic will be around oral health disparities and the Latino or Latinx community. And so take it away, Dr. Garcia.
So thank you so much, Dr. Smith, for the introduction and invitation to speak about oral health disparities and the Latinx community. This afternoon, I am Dina Garcia, and I am an assistant professor in the Department of Health, Behavior, and Policy at the VCU School of Medicine. I'm also a faculty affiliate with the iCubed Oral Health Horn. And before we begin, I really want to commend the leadership of Dr. Smith, who served as the impetus to launch this inaugural Inclusive Excellence Week, which provides a space throughout the week through these chats to not only celebrate diversity, equity, and inclusion, but hopefully each of the talks this week also will push us to critically think about how we as individuals, as a school, as an institution, can best propel diversity, equity, inclusion in every facet of our actions, including how we serve diverse populations, both in the clinics and in the academic setting. So today's focus of the session will be on the Latinx community. And we recently celebrated nationally, that was recently celebrated nationally through Hispanic Heritage Month, which runs from October 15 to September 15 to October 15. And this celebration started off as a week-long festivity in 1968 when Congress authorized the then President Lyndon B. Johnson to proclaim National Hispanic Heritage Week. And it was subsequently expanded to a month-long celebration in 1989. So nonetheless, it's important to continue to uplift the voices of members of the Latinx community beyond Hispanic Heritage Month, as we're doing today. And within the context of VCU, it also means to continuously support student groups on campus that provide support to Latinx students, such as the newly established STEM group affiliated with the Society for the Advancement of Chicanos, Hispanics, and Native Americans in Science, known through its acronym as SACNAS, which is a national organization dedicated to fostering the success of Chicanos and Hispanics and Native Americans, from college students to professionals in attaining advanced degrees, careers, and positions of leadership in STEM. In fact, this week, SACNAS is hosting its National Diversity in STEM Conference, which for the first time is being hosted virtually thanks to the ongoing COVID-19 pandemic. So again, I just want to reiterate that there's opportunities for engagement in supporting local Latinx STEM students throughout the SACNAS at VCU group, which I serve as the faculty advisor. So I'd be more than happy to chat with anyone that is more interested in learning more about this group or that wants to collaborate in future events. So today's talk will focus on two main objectives. First, I'll discuss oral health disparities with more of a focus on the social cultural context that gives rise to such disparities within the Latinx community in the US. And each of the points that I'll discuss could, in essence, be a whole course that's a semester long in and of itself. But for the sake of the presentation today, the discussion will be condensed. And later on in the presentation, I will describe how community engaged approaches can be utilized to address oral health disparities. So before we get started, I think it's important to define our population of focus for today's talk, given that several pan-ethnic terms have been used to describe the population of people living in the United States that identify as having Latin American ancestry. So to begin, the term Latino, which it's very commonly used, was adapted in the US by the US government to label individuals who identify as mestizo or Afro-Latino people from the Caribbean, as well as Mexico and the countries that comprise Central and South America, even those countries that are not Spanish speaking. The term Hispanic was first adopted in the US government during the Nixon administration and was implemented in the US Census in 1980. And Hispanic derives from the Latin word España, which later became España or Spain. And Hispanic refers to people who are from countries where the primary language is Spanish. Some people use the term interchangeably, but as I just defined them, there are indeed differences between the terms, so they don't exactly refer to the same groupings. Other terms that maybe you could have heard recently is Latin, ending with the at symbol at the end, or Latino/Latina, which are gender inclusive but binary embedded terms. We also have the term Latinx, which was born out of a collective aim to move beyond the masculine centric Latino and the gender inclusive but binary embedded Latino/Latina. And when the first term, when the term first emerged, it caused confusion among those who didn't know what it meant or how to pronounce it. And Latinx, this term is widely used within academic spaces and its online presence has continued to grow. So this week I searched the term Latinx on Google Trends, which is an analytics tool that tracks how often a particular search term is entered on a Google search engine. And the number of times that Latinx was used as a search term within the past 5 years is shown on the graph here on the screen. And we could see that it has grown in popularity throughout the years with a spike in 2015, but then also most notably a spike recently in September of 2020. However, to date, there's still some confusion or just plain utter rejection of the term Latinx within the Latino population. It's important to understand the historical similarities and differences between Hispanic and Latino, which have resulted in different meanings for these terms. But a key similarity between these pan-ethnic terms is that they both refer to a cultural and ethnic group and not a race, because people of Latin American descent comprise various races depending on their ancestry and context. So for the remainder of this talk, I will use the term Latinx unless a research study that I make reference to uses another term. So what do we know about the Latinx population in the US? Well, in 2019, the US Latinx population reached about 60 million, up from 50 million in 2010, making Latinx the nation's second fastest growing racial or ethnic group after Asian Americans. We also know that Latinx children are a growing segment of the US population. The percentage of children in the US who are Latinx has increased from 17% in 2000 to 25% in 2016. And nearly a third of Latinx in the US are under the age 18. So in regards to oral health, we know that there are persistent oral health disparities among Latinx in the US. For Latinx children, for example, they're more likely than children of other racial and ethnic groups to experience dental caries, and they also tend to receive fewer preventive dental services. And we know that this pattern extends to Latinx adults, where, for example, 44% of Mexican origin adults between the ages of 45 to 64 have reported untreated caries compared to 22% among white adults. There are also disparities in the periodontal health of Latinx adults, with data from the National Health and Nutrition Examination Survey, which we'll talk a little bit more in depth later on in this presentation, we know that the prevalence of periodontitis among Latinx adults is 64% among Hispanic adults that are ages 30 or above. So, the question that we ask ourselves as we hear this, different prevalence rates is, what is causing oral health disparities among Latinx in the US? And in answering this question, some scholars have focused on culture as a possible explanation for the differential patterns in oral health outcomes. So, for example, scholars that examine how culture influences health rely on the concept of acculturation, which is typically defined in US health research as an individual level process through which individuals acquire the behaviors, attitudes, values prevalent within the US. So the assumption is that as immigrants shed cultural characteristics that are presumably associated with their country of origin, and as they adopt those of the receiving society, so within this context, as they adopt those in the US, that this process influences social norms and individuals' health behavior. So in the case of oral health, this would be maybe adopting smoking habit or drinking or changes in dietary patterns, which in turn can have either a positive, negative, or mixed effect on health outcomes, as is illustrated in the simplified version that's on the diagram on the screen. And so research that assesses how acculturation impacts health typically uses proxy measures to define acculturation, such as nativity status, language preference, or length of time in the US, or the age of arrival to the US. Others utilize validated instruments or scales to measure acculturation. And the reality within oral health research is that there's no consistency across the board in regards to how acculturation is measured. The bulk of oral health research has used proxy measures to measure acculturation, largely due to the fact that most of the studies that assess the association between acculturation and oral health rely on cross-sectional data, such as the National Health and Nutrition Examination Survey, in which researchers really have no control as to which variables have been collected in the surveys. However, most surveys do typically include at least one proxy measure of acculturation, hence the reliance on this type of measurement. So now I want to go over an example of how one would go about using an existing survey data to assess the association between acculturation and oral health. So specifically, I conducted a study to examine the association between acculturation and periodontitis status among Mexican origin adults. And for this study, I used cross-sectional data from the 2009 and 10, 2011, 12 cycles of the National Health, Nutrition, and Examination Survey, which resulted in a total sample size of 993 Mexican origin adults. And within this study, periodontal status was defined using the CDC and AAP case definition for surveillance of periodontitis that we see here listed on the screen. And all statistical analyses were conducted to investigate the association between acculturation with total periodontitis. So that's the sum of mild, moderate, and severe cases as the outcome of interest. And within this study, acculturation was measured using two proxy measures. So using preferred language spoken at home, which was defined as either English or Spanish, and then also self-reported citizenship and nativity status. Other variables that were assessed in the study include demographic variables, access to healthcare indicators, as well as known risk factors for periodontitis. And as far as the statistical analysis, design-adjusted multiple logistic regression analyses examined the factors that were associated with total periodontitis. So here on the screen, I show that out of the 993 Mexican origin adults that were included in the study, 63% met the CDC and AAP case definition for total periodontitis. And as we could see also, a large driver of the prevalence of periodontitis in this population is the moderate cases of periodontitis, which account for about almost 40% of the cases. And when we compare the prevalence of periodontitis between Mexican origin adults to the broader US adult population, we definitely could see stark differences in the periodontal health. So as far as acculturation and periodontal health, we found that periodontitis was most prevalent among Spanish speakers and foreign-born non-US citizens, as illustrated here on the table in the slide. And even when taking into account other variables, including access to healthcare, what we found is that preferred language is significantly associated with periodontal status, right? So this is even accounting other variables, like I mentioned earlier, which corroborates a large size of body of research on Latinx adults, which suggests that acculturation typically improves the oral health outcomes of this population. And so, what specific aspects of language contribute to periodontal risk, right? So, as we think of this association between language spoken and periodontal health, what aspects of language contribute to periodontal risk? So, I want to go back to the diagram that I presented earlier, which outlined the process of how acculturation impacts health. And a core criticism of this perception of acculturation or simplified view or lens of how individual level changes, cultural changes influence health, a large criticism of this is that it largely ignores the broader social cultural context in which acculturation takes place, right? So many of you might have heard already of the social determinants of health, which refer to both specific features and pathways by which societal conditions affect health and well-being. And these determinants operate at all levels of society and within the context of broader systems of power, as we see on the screen. These determinants are referred to as the social determinants of equity. And social determinants of equity acknowledges that differences in health are rooted in social injustice. So if we are to examine the social determinants of equity, we are to, it requires us to determine the range, right, of observed contexts, right, in which people live and operate and grow up throughout their lifespan. And also it requires us to determine the distribution of different populations into those contexts. So social determinants of equity requires or involves the intentional examination of structures, policies, practices, and norms and values, and how those shape the lived experiences of individuals throughout their life course. And so assessing acculturation and how it impacts health should really go beyond assessing just how individual level cultural changes influence health to an approach that examines, for example, how the social and historical context of how structural factors such as public policies, labor practices, racialization processes, for example, how these intersect and affect the economic and social integration of immigrants, and really how this context likely affects health in broader ways than simply affecting an individual's cultural orientation. And so before I move on, I don't know if there's any questions that have came up through the chat. Otherwise, I'll keep going.
None at this time.
Okay, so The question, so now I'd like for us to analyze, how Latinx oral health trajectories are shaped by broader public policies, specifically focusing on public policies for immigrant health. And so to begin this discussion, let's give a little bit of context. Within the US, it's estimated that about 11 million undocumented immigrants reside in this country, of which 8.4 million are from Latin America and the Caribbean. And according to analyses from the USC's Center for the Study of Immigrant Integration and the Center for American Progress, nationally, more than 16.7 million people have at least one undocumented family member living with them. And about 1 in 12 children in the country are US citizens that live with at least one undocumented family member, which is referred to as mixed status families that contain both US citizens or lawfully present immigrants, as well as undocumented and unauthorized immigrants. And so immigrant integration policies can directly or indirectly influence health outcomes for immigrants and their culture. So for example, policies that directly influence the health of immigrants include those that explicitly enhance or curtail access to private and public health insurance and the provision of healthcare services through, for example, FQHCs or local public health departments. So now I want to give you an example of policies that curtail access to health insurance and healthcare services for immigrant populations. So within the US, undocumented immigrants face restrictions in accessing federally funded benefits, which dates back to the onset of the welfare reform in 1986. So specifically, the 1996 Personal Responsibility and Work Opportunity Reconciliation Act prevents the use of federal funding in Medicare, Medicaid, or other programs to provide coverage for services to undocumented immigrants or non-citizens with fewer than 5 years of US residency. Now, states do, however, have the option to expand eligibility for medical assistance programs to recent documented residents or undocumented immigrants. And then even years after the welfare reform, undocumented immigrants were still left out of the Affordable Care Act in 2010, as they're still not eligible to enroll in Medicare, Medicaid, or CHIP, or to purchase coverage through, for example, the ACA marketplaces. So some, undocumented immigrants may have funds to purchase private coverage through their employers or the individual market outside of the ACA marketplaces. However, with an average household income of about $36,000 per year, these coverage options may be unattainable, causing some to put off or delay needed care, or attempt to attain low-cost care through community health centers. So there's definitely health consequences of immigrant integration policies, but within oral health research, there has been minimal explicit focus on how such policies impact the oral health outcomes of Latinx in the US. So this led to a current study, which I am conducting in collaboration with Dr. Akinkunmi, a faculty member in the Department of Dental Public Health and Policy at the School of Dentistry. And in this study, we are examining the association between immigration status and oral health outcomes and dental care utilization by differentiating the legal status of non-citizens. So we're looking at how oral health outcomes differ between US-born citizens, naturalized citizens, documented non-citizens, and undocumented non-citizens. And to do this study, we're using the study of Latinos, which is a multi-center epidemiological study supported by contracts with the National Heart, Lung, and Blood Institute. And this observational longitudinal health study was designed specifically to document the health status of Latinx communities around the US. and also to obtain baseline measures for a wide range of conditions, including oral health. So a total of about 16,000 individuals ages 8 to 74 were enrolled at each of the 4 field sites that we see on the screen and have been followed prospectively to assess health outcomes every 36 months. So for the current health study that we're conducting, we excluded participants that had, missing data for legal status or dental care outcomes, as well as those of Puerto Rican descent, because they're U.S. citizens by birth and never at risk of being undocumented, which left us with a total study population of a little bit over 8,000, of which about 16% are undocumented non-citizens. As we see on the table on the screen, undocumented non-citizens were on average 36 years of age, a little less than half have been in the US less than 10 years, and almost 80% report a household income less than $30,000 a year, and almost 90% have no current health insurance coverage. Here on the screen, I present figures that are showing the unadjusted prevalence estimates for perceived dental care need, dental care utilization, which we defined as having visited the dentist at least once within the past year, and also periodontal status, which was also assessed using the CDC and AAP case definitions, which I defined earlier. So, and each of these are graphed by immigration status. So as you can see on the figure on the left, 85% of undocumented non-citizens reported having a dental care need. As we see in the figure in the middle, we can see that undocumented non-citizens were more likely to report not having visited the dentist in the past year compared to US citizens. And as we see on the figure in the far right, it's the unadjusted prevalent estimates for periodontal disease. And we could see that there's definitely undocumented non-citizens have a higher prevalence compared to US citizens. So obviously across the board within each of these different figures, we definitely see disparities, not just in perceived dental care need and dental care access, but also in the oral health status of undocumented non-citizens. So this data for this study is still ongoing, and today I only presented the unadjusted prevalence estimates for oral health and dental care utilization indicators. So next, we will conduct logistic regressions to model the relationship between immigrant status and oral health outcomes after adjusting for socio-demographic and behavioral variables and insurance status. So this study is an example of how policies can curtail access to health insurance and healthcare access for immigrant populations. And in assessing the impact of immigrant policies and how they impact health, it's also important to examine how policies can also cause worry, stress, and fear among immigrant communities. So for example, in 1996, Section 287G of the Illegal Immigration Reform and Immigrant Responsibility Act granted state and local law enforcement jurisdictions the option to operate in enforcing federal immigration laws. And local police collaboration with deferral immigration law enforcement through an increase in, for example, immigration rates, perpetuates a culture of stigma, of fear, of discrimination that not only exacerbates distrust between the local law enforcement and community members, but that also may propel undocumented individuals to not seek help or healthcare in fear of deportation. So for example, aside from this Proposition 287G, the recent changes that are happening nationally with the public charge rule, for example, which is used to determine if someone will be allowed a green card entry into the US or face deportation, which mainly impacts individuals that are seeking permanent residence status through family member petitions. But this rule stipulates that legally using Medicaid coverage or other federally funded programs could count towards a person's immigration status, which obviously could have chilling effects on families' use of dental care, for example, as immigrant families could avoid participating in programs in fear of risking a family member's opportunity to become a permanent resident. And if you recall earlier in the presentation, I stated that 1 in 12 children in this country are US citizens that live in at least one, with at least one undocumented family member. So these immigration actions impact quite a few number of families. And it's also important to note that policies can also indirectly influence health. So this includes a broader assortment of social policies, for example, that influence the availability of socioeconomic resources that are essential to the production of health. So this refers to perhaps educational attainment, employment, income, housing, and as we see on the screen, it also includes driver's license. So this summer, Virginia became the 17th state to give the right to drive to undocumented immigrants, which indirectly can also be linked to health. So without a doubt, policies can directly or indirectly influence the health of immigrant populations in the US. So up to this point in the presentation, I discussed how the social cultural context gives rise to oral health disparities among Latinx population in the US. Before I move on to the next objective, are there any questions that have come up in the chat?
No, not at this time. We also have a Q&A block. If any participants would like to ask a question of material that Dr. Garcia has offered already, you can put that in the Q&A or in the chat, and I'll make sure that she sees it.
Okay, great. So now I'm going to shift a little bit and I'm going to discuss how community engaged approaches can be utilized to address oral health disparities. So within the field of public health, there's agreement that developing sustainable solutions or mobilization efforts to address the persistent disparities or health disparities requires an approach that's different than what we've done thus far, right? An approach where communities are involved in the research process and an approach in which communities are at the forefront of such action. And involvement of community within a research process can vary from more community place-based research where you go to a community's site and just collect information, to maybe more community engaged research where community members are involved in certain aspects of the research, to then community-based participatory research where both the researcher and community members are partners that co-equally create the research question from beginning to end. And then towards the end, more of community-driven research where it's actual community members that are coming up with these research questions and methods and are driving these agendas. So irrespective of where along the spectrum engagement of community lies, it's important to note that addressing health disparities, or the common perception within public health research, is that community members should, regardless of where in the continuum, be involved in the research process. And so now I want to give an example of how I have used a community engaged approach to address an oral health disparities issue in my own community. And so here on this screen, you see a picture of Cesar Chavez Drive, which is located in Milwaukee, Wisconsin, so in the heart of the Mexican community in Milwaukee. And this is where I grew up. So I was born in Guadalajara, Mexico, and I immigrated to the US when I was 2 years old to Milwaukee. And I spent a lot of time in my youth precisely on Cesar Chavez Drive. This is where we bought our groceries. This is where we went to church, right? So this is the community where I grew up. And when I had the opportunity to conduct my own dissertation work, I had the opportunity to do it in my hometown. So my research explored acculturation and how that was linked to the oral health status of Mexican adults that have diabetes. And so when I was in Milwaukee and I was doing my research, I conducted several focus groups with Mexican adults in the community. I thought to myself, well, obviously I'm going to publish this research through academic journals and also presentations. But how can I ensure that members of the community that both participated in the research and that also live in the community can have access to these research findings? So this propelled me to use the arts to create what I later became known as the Milwaukee Diabetes and Oral Health Art Gallery, which was a way in which we use art and local artists to create different art pieces that were informed by my research findings as a way to disseminate the findings to the broader community. And so to do this, I recruited 11 local Mexican origin artists to develop the art pieces that were inspired by themes of my research study. And within even the artists that were invited, they were excited to be part of such initiative. You can see the quotes on the screen. Some of them said, I love that we're incorporating art and science to make a difference and engage the community. Another artist said, growing in a small community in Mexico, I saw the huge need for these resources and how much people needed to be educated about oral health. So there was definitely a lot of interest from artists to be part of this process of disseminating research through art. And the artists use a wide range of different mediums to create their art pieces, ranging from acrylic, paper mache, projections, sculptures. And here, on the slide, on the sides, you can see the different art pieces that were created. And in the middle, you see some of the artists that participated in this project. And the exhibition was guided by the research theme. So each of the 6 themes of the dissertation work were displayed in a section of the gallery as illustrated in the gallery layout map that's on the right. And then the image on the left of the screen shows the actual art gallery installation and how it was depicted. And so at the end, we had a section in which called the interactive wall, where gallery attendees jotted down on Post-it notes their impressions or comments and thoughts regarding the gallery experience. And so the gallery opening reception was held on November 20th during Diabetes Awareness Month. And here we could just see a few of the pictures from the gallery opening night, which was attended by an intergenerational audience of individuals both from the Cesar Chavez Drive community and more broadly across Milwaukee. And the opening reception also included a group, a dance group, in which different middle school children danced. Are y'all still able to see my screen? Okay, sorry, I was seeing the chat. And the Diabetes and Oral Health Art Gallery stirred a lot of interest even more broadly beyond the gallery in and of itself, that the Office of the Mayor and the Common Council both declared the gallery opening day as Diabetes and Oral Health Awareness Day in the city of Milwaukee. And additionally, the gallery was highlighted in several local and national news outlets, including the American Dental Association News, as well as locally the Milwaukee Neighborhood News and El Conquistador. So aside from disseminating the research findings, the Milwaukee and Diabetes and Oral Health Art Gallery just deepened the community organizing and mobilization efforts centered on achieving health equity. So soon after the art gallery was launched, several community organizations that served the neighborhood, the Cesar Chavez Drive neighborhood, convened to discuss the intersection of community, of the arts and action. And so communities came together to support a youth-led mural on health equity that was then painted the summer after the gallery to on the exterior. It was painted on the exterior wall of the exhibition space. And the Milwaukee, here's a final picture of the health equity mural that was also recognized in the National Academy of Medicine's Visualize Health Equity Initiative, which just goes to show that, you know, when we started this gallery idea, or even the idea of recruiting artists to create art pieces, we never would have thought that the gallery itself would go viral, right? And that it would go viral, not just, you know, with the pieces and the concept, but alongside the stories, right, of participants of the research project. And so if you're ever in Milwaukee, you go to Cesar Chavez Drive and at the intersection with Scott, you'll see the health equity mural, which is an example of how we could incorporate community members in this broader process of increasing awareness, right, of oral health, the importance of oral health, disparities that are impacting the communities, which could then propel more organizations to collaborate and create a unified voice in regards to how to move forward and address issues that are propelling such disparities within communities. So within this session, we've discussed, you know, social cultural context that gives rise to oral health disparities. And hopefully in the second portion, by sharing an example of how I use the arts to disseminate oral health research, it also gives an idea of the importance of integrating communities within every facet that we do. And so hopefully that also inspires others to, if it's not the arts, to think outside the box of different ways in which we could mobilize towards health equity. So that's the end of my presentation. We could definitely open it up for questions.
Yeah, so it looks like, thank you so much, Dr. Garcia, for that presentation. It was very, very rich, and I'm a history buff, so I really appreciated you starting, excuse me, with a lot of history around the terminology. So I think that's very informative for us as a whole, as healthcare providers, but also just as co-humanity with folks and how they prefer to be identified. We do have at least one question thus far, and so everyone else can start questions coming in either through the Q&A or the chat is fine. So we have one question around improving access to healthcare, in particular oral health. And one way that we do that is by increasing the number of dentists from a particular background, right? So the question is, with your research and experience, particularly I imagine around community engagement, would you have any potential recommendations on how we can promote dentistry as a career?
Definitely. Well, for sure, I think that it begins with addressing different disparities that are prevalent within our own education system. I think that there's definitely a growing interest in Latinx students, for example, in STEM careers, which would include something like dentistry. And then somewhere along the pipeline, either through not having mentors or other structural issues within the household or the neighborhoods, that sometimes students get lost, not because they are not able to pursue these careers, but because maybe there was inadequate support to mentor students. So I think one important method is definitely through mentorship. of students, and not just, once they get to college, but, from the beginning, from K to 12. And here within the context of VCU, for example, I mentioned earlier, there's the SACNAS at VCU chapter, in which I know firsthand there's quite a few number of students that are a member that are pre-dental, right? And that they want to pursue a career in dentistry. So I think that there's definitely opportunities, even if we don't go beyond the broader community, if we focus within VCU, of how it is that we can partner with organizations that have been established on campus, where we could have direct access with students that are interested, but that perhaps haven't been connected to a mentor, that perhaps want a research opportunity, but don't know how to go about it. So I think that that's one approach, definitely in terms of how we can increase awareness, first and foremost, of dentistry as a profession, but also being very intentional in addressing the mentorship component. I could tell you even the SACNAS group, for example, recently developed a mentorship program with a local high school. And there was great interest from the high school in connecting the Latinx high school students with mentors from the SACNAS chapter, because there's really this need, right, to understand how to navigate the education system in terms of applying to college, what type of major, what type of classes. So definitely, I think there's opportunities in terms of partnerships, and in turn, these spread out into the broader community outside of VCU. So I hope that answered the question somehow.
Thank you so much. Other questions at all? You can put those in the chat or the Q&A. It looks like we have a few coming in. As a result of the diabetes awareness art exhibit, was there an increase in Latinx community members seeking healthcare services?
Yes. So the answer to this question, so we didn't systematically do an assessment of how many people, whether there was an increase or not increase in seeking services. But obviously, my family still lives in Milwaukee. And so we know that there was a lot more individuals that were even calling the gallery space and asking, oh, how is it that we could, go to a dentist? Which are the dentists that accept our type of insurance? And actually, what this initiated is that several local organizations that serve residents of the Cesar Chavez Drive community, they met with their local representatives. So I think State Representative Jocasta Samaripa, for example, there were a couple conversations in terms of how it is that we could expand support for community centers, specifically as it pertained to access to dental care. So I think that's a prime example of different of the need, right, to not just have more people go and get treatment, but how it is that we could involve your local politicians and also different community organizations to have those conversations of how it is that more support, the infrastructure could be strengthened to provide adequate access to services for the population. So thank you for that question.
Thank you so much. There's also a question. I know that you explained that Latino, Latina, Latinx is not a race, but a common heritage. Could you please give us a little more description about the difference in race versus heritage?
Yeah, so as I mentioned, Latino, Hispanic are pan-ethnic terms, right, that refer to a group of people that are from Latin American ancestry, right? So within each of this group of people, you could have people who are of Mexican origin, right, of Cuban origin, of Puerto Rican origin, right, of different countries, right, is their ancestry. And so that's what's referred to as ethnic identity, right? In terms of, for example, me, I was born in Mexico and grew up in the US, but my ethnicity is Mexican. And so within that concept of ethnicity, so where your ethnic origin is from, right, is different than race. So race is a socially constructed way of viewing individuals, right? So within the context of a US, race is, a white individual, a Black individual. And so that is completely different than ethnicity because race is socially constructed, right, in terms of how our social context has been developed. So individuals that are of Mexican origin, of Cuban origin, of Puerto Rican origins that, are within these pan-ethnic terms of Latino, they could be different racial backgrounds, right? They could be white, they could be Black. And I think that that's where even now more and more there's more not awareness, but folks are being more vocal of the great proportion of Afro Latinos that are represented within Latinos and Hispanics, which I think is an important aspect to understand. So I think that was a good question. So thank you.
Awesome. Thanks for that. And I will just add, I think one of the things, again, as sort of a closeted history buff myself, who's from South Carolina originally, there's a lot of growing research around the fact that when you look at the influence of the Atlantic slave trade, right? So how various racial groups that descend from Africa made their way to the Western world. There's lots of evidence that actually more slaves were brought to Central and South America than even to the United States. Obviously, we're in the United States and many of us are from here. And so we think of that as kind of a primary context, but it's really fascinating once you start doing some research that we actually have less slaves that were brought here originally than some of the other southern areas that are in South America and have more of a maybe Latino or Latinx influence. Other questions at all from anyone around this awesome presentation? I have one. Could you speak a little bit to why you felt it important to engage the community around perhaps a need that they self-identified, like art education or what have you in that instance, versus I think sometimes communities, and rightly so because of historic things that have taken place, communities have maybe a distrust around studies and surveys and things and investigation from academia. So could you speak to the ways in which the community engagement piece helps to mitigate that?
Yeah, for sure. So as you recall, the study that I conducted was looking more at the oral health status of Mexican origin adults that have diabetes. And so within that context, as I was thinking of, how is it that I could, break down that wall, that barrier between academia and research, because obviously there's been a wide variety of injustices have been committed in the name of research, right? Let it be from Tuskegee experiment to even sterilization of women in Guatemala. So there's definitely mistrust that stems from, rightfully so, from individuals in terms of research. I don't know if I want to be a part of that. And then you add these other layers, as I mentioned in a presentation, of the social cultural context and immigration, in which folks could someone be wary of, I don't know if that's something I want to be a part of. And so thinking back again, that my population of focus were Mexican origin adults in the Milwaukee area, I started thinking and looking back of, what methods have been used within this particular community to mobilize towards action. And so the arts actually have been used as a way of cultural identity, of mobilization within the Mexican origin community, the Chicano community for, many, many years. And this dates back even in the 1960s, when or early on with Cesar Chavez, for example, and they were mobilizing for the rights of farm workers. They also utilized, for example, Teatro Campesino, which was a theater group of the oppressed, which highlighted some of these injustices through theater. Even now, in present day, we have groups like Dignidad Rebelde, which is a group based out of Oakland that does different prints that highlight different social injustices that are occurring worldwide, specifically within Latinx groups. And so with that in mind, in terms of the arts have historically been used as a way to mobilize towards action, then that's where I kind of got the idea of, okay, well, maybe, let's use the arts, right? This is something that our people, that Mexicans have used for many years. This could be a great way to now use it with research. And I think within my particular aspect, it helped out that I collaborated with my own sister, and she's a local artist in Milwaukee. Now she runs an art center in the city. And so that also helped gain trust with the different artists that were recruited in the process. And I think that that's important because, when you think of what strategies to use to engage communities, think of, what has been used traditionally within those communities. I think oftentimes there's this idea that there's, so many deficits and issues within these communities. And on the contrary, that's not the case, right? There's a wealth of strength. There's a wealth of community wealth in different communities. And in the case of Milwaukee and the Cesar Chavez Drive community, right, there's many artists that have beautiful pieces that they create. And so this was an opportunity to use a community-based approach that was based on existing community strengths and assets, right? So it's an assets-based approach to engage community members towards action.
Thank you so much for that. I think we have maybe time for one or two more questions if someone else wants to place something in the chat or the Q&A. I could ask more questions, certainly. I think it would be important. Some of our audience are private practitioners or clinicians outside of the academic space. And so one of the things that I know holds true in private practice are maybe perceived stereotypes around access to care, barriers to care. Particularly, you brought up the fear that may be perceived around questioning immigration status and things of that nature, even when, say, for instance, the financial obligation is met through something like Medicaid. Could you maybe elaborate on that a little bit for our audience that may be in private practice and not in academics?
Yeah. So like I mentioned earlier, right, within the US, there's a wide range of folks of Latino heritage. And I don't, not everyone is undocumented, right? But there's a portion of the population that is. And what's important to note is that within households that have, for example, a mixed status, let it be a parent that is undocumented, but the children are not, if a parent has fear of perhaps being caught in a raid, let it be on the way to a dental appointment or on the way to their job, etc., they might not be as likely to attend their dental care or to seek the services because there's that actual fear of potentially being caught, right, or stopped and deported and separated from their families. And so it's very important to understand that concept of mixed status households, right? Whereas perhaps maybe children that are born in the US and whose parents are undocumented, right? They are US citizens by birth, and obviously they may qualify for different services, but that oftentimes, because of the fear that is perpetuated through the current context in which we're currently living within the US, that even they themselves may not be accessing the care. And so I think it's also important to, as practitioners, have different families that come to the dental care setting to also understand how legal status has been used, right? to propel discrimination or to stigmatize individuals. And so it's very important to also proceed with caution, right, in terms of how you address families and the type of questions that are asked, because we really don't need dental practices to become another place, right, where fear or discrimination is something that's being perpetuated or faced by the community members that are seeking services. So I'm not sure if that answered the question.
No, I think that's great. Thank you so much. Excuse me. So I believe that's all we have time for this afternoon, but it was really such a rich conversation, and hopefully, as Dr. Garcia alluded to in the beginning of our presentation, this is really just the beginning of multiple dimensions of conversations around how diversity, equity, and inclusion intersect with our educational mission and also our health mission as oral healthcare professionals. And so we just thank you so much, Dr. Garcia, for sharing with us today and spending some time with us today. Looks like we might have one more comment that's just encouraging, saying excellent presentation, Dr. Garcia. So we just thank you so much for your time, and everyone have a great afternoon.
Thank you.